Hello everyone, my name is Changhwan from the Department of Radiology at Asan Medical Center. I'm honored to present our original research titled Transarterial Radioembolization versus Transarterial Chemoembolization in elderly patients with Hepatocellular Carcinoma, a propensity score-matched comparison. To provide some background, TACE remains the most widely utilized initial treatment for newly diagnosed HCC in South Korea. However, TACE is associated with ischemic injury and a well-recognized cause of post-embolization syndrome. TARE delivers 8-90 microspheres while preserving arterial patency, resulting in less ischemic injury and fewer post-embolization syndrome, which can place a significant burden on elderly patients with reduced physiologic reserves. Thus, the objective of this study was to compare the clinical efficacy and safety profiles of TARE versus TACE for treating elderly patients with HCC. Moving on to materials and method, this was a retrospective single-center study conducted at Asan Medical Center spanning from November 2021 to November 2025. We screened treatment-naive HCC patients aged 75 or older. We exclude patients who received concurrent treatments, those with other active malignancies, extrahepatic metastasis, or baseline liver function of childhood class C, as well as those lost to follow-up. TACE was performed using conventional chemoembolization techniques. For TARE, either glass or resin microspheres were used. Treatment planning included Propensity and technetium-99 MAA scintigraphy. Dosimetry was based on pre-treatment scintigraphy because post-treatment PET-CT dosimetry software was not available during the study period. Follow-up laboratory tests and contrast intensity were performed at 1 month and periodically thereafter. The treatment response of the index tumor was evaluating using modified RECIST criteria based on only the best response achieved after the first treatment session. Adverse events were retrospectively reviewed 90 days of the procedure and graded according to SIR guidelines. Delayed TARE-associated toxicities were assessed for up to 1 year after treatment. For statistical analysis, 1-to-1 propensity score matching was performed. Covariant balance before and after matching was assessed using standardized mean difference. For comparison of treatment to response rate and adverse events, the chi-square test or Fisher's exact test was used as appropriate. The Mann-Whitney test was used to compare hospital stay duration. TTLTP, TTP, and OS were estimated using the Kaplan-Meier method and compared using log-length test and hazard ratio, with TACE as the reference category, calculated using Cox proportional hazard regression. A two-sided p-value less than 0.05 was considered statistically significant. I will now present the result of our study. After screening 379 other treatment-naive HCC patients, 55 TARE and 264 TACE patients were identified. We performed 1-to-1 PSM and successfully yielded two well-balanced cohorts of 55 patients each. Table 1 shows detailed patients' characteristics. Before matching, the TARE crew comprised patients with significantly larger tumors, a higher prevalence of ECOG performance status of 1 or higher, high AFP level, and a greater proportion of patients aged over 80 years. Table 2 summarizes the TARE specific procedure parameters. The resin to glass ratio was 38 to 17. The median tumor observed dose was 727 gray for the resin microspheres and 636 gray for glass. In terms of initial tumor response shown in Table 3, the complete response rate was higher in the TARE group at 54.5% compared to 34.5% in the TACE group. This difference achieved marginal statistical significance with a p-value of 0.055, but objective response rate remains comparable between the groups. Review the survival and progression kinetics. Time to local tumor progression was significantly longer in TARE group. Figure 3 shows that the median TTLTP was significantly prolonged in the TARE group compared to TACE group. The median TTLTP was unreached for TARE, whereas it was 18.5 months for TACE. However, as shown in Figure 4, the overall time to progression did not differ significantly between the groups. Also, overall survival was not significantly different between groups. Median OS was 31.7 months in the TARE group and was not reached in the TACE group. Early mortality within 1 year occurred twice as frequently in the TARE group, 12 patients versus 6 patients in TACE group. TARE demonstrated a superior tolerability profile. Mild to moderate abdominal pain was significantly less frequent in the TARE group at 5.5% versus 21.8% for TACE. Most importantly, severe adverse events classified under the SIR guidelines were dramatically lower in the TARE group than the TACE group, with a p-value of less than 0.001. Furthermore, the median length of hospital stay was significantly shorter in the TARE group. Two fatal cases were observed in the TARE group, including radiation pneumonitis. This study reflects real-world practice in South Korea, where TARE is often selected for older patients with larger tumors and poorer performance status. Despite these unfavorable characteristics, TARE demonstrated better tolerability, lower rates of severe adverse events, and significantly better local tumor control. High tumor observed radiation doses in the TARE group might account for better local tumor control. In addition, preservation or even improvement of health-related quality of life might represent another important advantage of TARE, particularly in elder patients with reduced physiologic reserves. Taken together, these findings may suggest that TARE may be an attractive local result treatment option for older adult patients with HCC. However, improvement to local control did not translate into an overall survival benefit, likely because survival in HCC is influenced by other factors. Our study has several limitations. First, due to the retrospective design and relatively small TARE cohort, an inherent structural selection bias was unavoidable during the PSM process. Before matching, patients in the TARE group had larger tumor, poorer performance status, and were older, reflecting the real world in South Korea. Consequently, matching increased the median tumor size in the TACE group from 3.4 to 6.2 cm. Second, the higher proportion of childhood Class B patients in the TARE group likely reflects early referral patterns during the initial implementation of our institutional TARE program. Third, the resin microsphere subgroup received a relatively high tumor observed doses, which may be attributable to the institutional learning curve during the early adoption phase. Fourth, heterogeneity in post-treatment management and subsequent rise of therapy may have influenced the long-term outcomes. Lastly, this was a single-center study. In conclusion, in a population of older adults with HCC enriched with patients typically considered for TARE in clinical practice, TARE demonstrated a more favorable safety profile and better local tumor control than TACE. Therefore, TARE may be preferentially considered for elderly patients with larger tumors or reduced physiological lesions. Thank you for listening.